Hello and welcome to Unstressed. My name is Dr. Ron Ehrlich. Well, today we are going in for a checkup with my cardiologist, Dr. Ross Walker. Now, Ross is an absolute legend in Australia. He is an integrative cardiologist, which means he has an open mind to not only the use of pharmaceuticals, but also an evidence-based approach to nutritional and environmental medicine. He has written, I think it's up to 6-7 books. He has a weekly national radio program, and I always enjoy talking to him. I was visiting with him in having my yearly checkup just a few weeks ago, and I sat and spoke to him, and I thought to myself, what a shame I didn't have my microphone with me. So here we are sharing that conversation with you now. So I hope you enjoy this conversation I had with Dr. Ross Walker. Welcome to the show, Ross.
Thank you, Ron. It's an absolute pleasure to be here.
Ross, always, we caught up just recently in my annual heart check, which I always hate because you put me on that treadmill and I don't usually run. But anyway, it was so good to catch up, and we started talking, and I just said, listen, got to get you back on because, there's so much to cover. I mean, cardiovascular disease, where are we globally, cardiovascular disease? Just remind our listener of how we're going.
Well, cardiovascular disease, Ron, is still the biggest killer in the world. There are around 17 million deaths every year from cardiovascular disease. Cancer is coming in a pretty close second, but it's still cardiovascular disease is number one. And even despite this pandemic we're all going through at the moment, nothing like cardiovascular disease. Interestingly, at the start of the pandemic, I went on television and I said, look, if everyone's that worried about their health and security, stop stockpiling toilet paper, stockpile fruit and vegetables and exercise equipment, because one person dies in Australia every 12 minutes from cardiovascular disease. Nothing like the death rate we're seeing from COVID, which is still there and it's still modest, but it's nothing like cardiovascular disease.
We've become so used to or focused on getting daily death rates, isn't it? That when you start to say a person dies in Australia every 12 minutes.
Yep.
And cardiovascular disease is serious, what we now refer to chronic disease as comorbidity. That's a new term people are becoming familiar with. So it's still a pretty major problem. I mean, we've been on this food pyramid and statins for over 40 years now. I would have thought cardiovascular disease would have been solved just following that advice. How have we got it so wrong?
No, we'll get to that as we go on, but there's a lot of factors with that one, my friend. I'll talk about that when I answer your questions a bit later on.
Okay. Well, let's talk about what those risk factors are.
Yep.
What should people be looking at? I mean, I'd like to think of this as my listeners' visit to the cardiologist.
Okay. Well, firstly, there's three sort of people that see me, three types of people. One, what we call secondary prevention, and they're people who've already had the heart attack, the stent or the bypass, and they come for ongoing management. Because the point is, in my view, if you've had a heart attack, stent or a bypass, it should be one per customer. And even if we had no further advancements in medicine, I believe we can keep people alive till they're 100 with our current therapies, which also includes lifestyle, which we'll get onto in a second. So we have magnificent treatments now for people, both lifestyle, pharmaceutical and natural therapies. But unfortunately, not everyone avails themselves of those therapies, but we can get onto that in a second. So yes, we have really had enormous advances. You say, well, hang on, if we've had enormous advances, why is cardiovascular disease still our biggest killer? Well, let's put it in perspective. In the 50s and 60s, we had the highest rates per head of population of cardiovascular disease in the modern world, and that's been reduced by about 60 to 70%. I think you can still bring it down to close to zero, but it's been reduced by 60 to 70%. So we have made enormous advances. Now, You and I, Ron, went to school together, and I started medicine and you started dentistry in 1974.
Yes.
Back then, if you had a heart attack, you had about a 30% in-hospital death rate, 30% in hospital. Wow. Now it's about, at the very most, up to about 3%, and that's for the sickest of the sick as well. That's for very sick elderly people. and across the board about a 3% death rate. But for fitter, younger people, say below the age of 75, you're talking about a less than 1% death rate going in with a heart attack, as opposed to 30% 40, 50 years ago.
Significant improvement.
Significant reduction.
Yeah. Yes, well, and you're putting that down to the stents, the bypass,
I'm putting that down to all of the above. So let me put this in perspective for you. 80% of anyone's management, and we've got a lot better on this over the last 40, 50 years, 80% has got nothing to do with doctors. Doctors aren't that powerful. What is powerful is how you look after yourself. But before I get onto that, I want to make a big point here. Cardiovascular disease, cancer, Alzheimer's, osteoporosis, diabetes, all of our modern killers are absolutely genetic. You can be the healthiest person in the world and still drop dead in your 40s or 50s if you have lousy genetics. But your genes loads the gun, then your environment pulls the trigger. So if you've got moderately bad genes for heart disease, but you look after yourself very well, you might have a huge buildup of calcium in the wall of your arteries, but nothing actually happens. So let's just talk, we'll get on to calcium scoring because it's very relevant to this conversation.
Yes,
it leads into it.
Yep.
And I've been doing calcium scoring since 1999. I introduced it into Australia back then. And so the good thing about a calcium score is it gives you a grading of how much muck you have in the wall of your arteries. The calcium doesn't matter a hang, but it's a marker for how much fat you have. So a 0 score is what you want. 50% of males age 50, 50% of females age 60 have a 0 score. But if you're a pessimist, that means 50% don't. And they're the ones who are at higher risk. Now, even if your score is 0, you're not at 0 risk, you're at just much lower risk. So I still occasionally see people who are in the much lower ranges of calcium scores up to about, say, 50, who still end up having a heart attack, but it's caused by something different that we can get onto a bit later.
But just to remind our listener, Ross, because you and I know what we're talking about here, and it's the coronary calcium CT score, which is different from what a lot of people have had when they go in for an angiogram tell us, go back to, let's assume our listeners never even heard of this coronary calcium CT score.
Well, the coronary calcium score is done on a advanced CT scanner and the ones we have these days are very low radiation, so you can forget about the radiation risk, especially if you're over 50. There are only 3 advantages of being over 50. 1 is wisdom, 2 is grandchildren if you got them, and 3 is you lose the cancer risk from medical radiation. So forget about getting a cancer out of a CT scan, just not going to happen over the age of 50. So the CT scanner takes a picture, non-invasive picture, no dye, no injections, non-invasive picture of the calcium buildup in the walls of your arteries. It doesn't tell you about blockages, doesn't tell you about anything at all like that. It just tells you how much calcium you have. The calcium doesn't matter. So if you imagine a donut with a hole in the middle, that's where the blood's going, but all the fat's sitting in the wall. The body then throws in calcium like a scaffold to stop it from breaking down. So the calcium is actually a reparative response by the body to fat buildup in the wall of your arteries. But it's still been shown very clearly, the more calcium you have, the more muck you have in your arteries, the more atherosclerosis you have. So what you want is 0, 1 to 10 is trivial, 10 to 100 is mild, 100 to 400 is moderate, and above 400 is don't read Tolstoy.
Gosh, I remember you telling me that years ago, Ross, and I haven't picked up that book. I was going to read it, but I just following my cardiologist's advice.
No, but that's only if you do nothing about it.
I know.
Again, at the European Society of Cardiology meeting in September last year that I had the pleasure of going to in Paris, a fellow presented a paper showing clearly that if your coronary calcium score is below 100 over the age of 50, you do not need to be on a statin. So the only people who need to be on a statin are people who have either had heart attack, stent, or a bypass, or their coronary calcium scores above 100. Once you get above 100, there's a highly statistically significant benefit from being on a statin. But I don't care what your cholesterol is. If you've got a 0 score over the age of 50, you don't need a statin. So I'll give you one great example. I've got a 32-year-old woman, and I would hardly ever do a calcium score on a 32-year-old because there is a small amount of radiation, and younger people have more actively dividing cells, so they're at a greater risk of getting cardiovascular disease, or getting a cancer from radiation. So anyhow, this woman, I sent her downstairs for a calcium score, and her score came back at 48. Now that's in the middle of the mild range, but it's a huge amount for a 32-year-old woman. So I'm hammering her cholesterol of 12.4 with a statin, 40 milligrams of Crestor, the strongest statin, ezetrol, because I've got to get her cholesterol down because she will probably have a major cardiac event without that. But I've got a 58-year-old woman with a lifelong cholesterol of 9.5, again, familial hypercholesterolemia, and you give her a statin for a few days, she can't lift her arms, sent her downstairs for a calcium score, nothing, came back 0. So she doesn't need a statin. Now that's almost medical heresy. Cholesterol 9.5 has got to be lowered with a statin. No, it doesn't if you have no muck in your arteries. So don't treat cholesterol, treat risk. But as I was saying before, 80% of anyone's management is firstly, number one, have no addictions. You cannot be healthy and smoke, drink too much alcohol, or snort cocaine. So anyone who has any addictions to anything is sick. Number two is good quality sleep. 7 to 8 hours of good quality sleep is as good for your body as not smoking. Number three is nutrition. Now, everyone talks a lot about nutrition, but it's very easy to summarize. It's called eat less food, eat more natural food. That's all you need to know. Number four is the second best drug on the planet, 3 to 5 hours every week of moderate exertion. And let me make the point here. If I give you a statin, I lower your risk for a heart attack about 20 to 30% in an average dose. If I get you to have a 3 to 5 hour a week exercise habit, I reduce your risk for heart disease 30%, cancer 30%, Alzheimer's 30%, diabetes 30%, depression 30%, osteoporosis 50%. I drop your blood pressure and you sleep better. There is no pharmaceutical preparation known to man that comes anywhere near exercise. Exercise is the second best drug on the planet, the best drug on the planet being a thing called happiness and stress management. So that's 80% of our management. There was a study called the Morgan trial, MORGEN trial out of Holland, showing that people who practice those 5 keys to the best of their ability compared to people who were the worst at doing it, an 83% reduction in cardiovascular disease with no side effects, as opposed to taking a pill, a 20 to 30% reduction in cardiovascular disease by taking a pill with the potential for side effects. So I'm not saying you should either do lifestyle or take a statin. If you've got a high calcium score or you've had problems, do both. But don't see the pill as being the key. This is what really disturbs me. People say, I'm taking Lipitor or Crestor so I can eat what I like. That is complete and utter biologic nonsense to think like that. It's a supplement. The pill is a supplement to your healthy lifestyle, as are natural therapies. A lot of people who take natural therapies and think, I can loosen a bit on my lifestyle because I take all these natural therapies. That's nonsense as well. So those 5 keys are 80% of anyone's management. And I think we should all be doing that. And then you build on that management based on the person's level of risk. So again, if someone has a calcium score over 100, I'd give them a statin. Would I give them a baby aspirin? No. Because 3 major trials in 2018 showed that if you're perfectly healthy and have moderate risk for heart disease, then aspirin does absolutely nothing, but it may upset your gut, may give you reflux. If, however, your calcium score was well above 400, I'd probably add a baby aspirin there as well. Over the age of 60, Ron, and this is absolutely key, high blood pressure is a much more important cardiovascular risk factor than cholesterol. So I've got people who are on their 10 or 20 milligrams of Crestor or their Lipitor, and they come in, they're delighted, their cholesterol is 3.5 millimoles per litre, and their blood pressure is 160 on 100, and they're about to pop a hole in their head. So you must manage manage blood pressure regardless of somebody's cholesterol or their cardiovascular risk. But cholesterol only needs to be managed if you're at higher risk with a higher calcium score or a history of vascular disease, but you've already had the stent, the heart attack, the bypass. So we've got to really look at blood pressure management. That's vital. We do all of those things. And then for people I see in my own practice who do the best are people who, A, lifestyle is king, that's 80%. The 20% left is the appropriate use of pharmaceutical drugs, the appropriate use of high quality evidence-based supplements, because many conservative doctors think all doctors do is give you expensive urine. But what I say is they also give you valuable blood if you take the right ones with the right evidence behind them. But that's the third component. So lifestyle, pharmaceutical therapy if necessary, appropriate use of supplements. Number 4 is to go for regular follow-up. So there's no point just having your one-off check and think, oh, I'm fine or I'm not fine. If you're very low risk, maybe every 5 years with your cardiologist if you need to see a cardiologist. If you're at higher risk, maybe every 1 to 2 years you need to come for regular follow-up. And here's the final key, point number 5 there, is that if you have symptoms, you need to get a check. There was a study done of 22 people who died suddenly of heart disease. 21 out of 22 had told a doctor or a relative in the week before they had chest pain and they ignored it. And that's why they died suddenly. You always get a warning before your vascular event because, as I said, the donut, the fat sitting in the wall, it suddenly goes, but you firstly experience that initial rip in the lining of the arteries and gives you chest discomfort. And then the clot that forms on top of that rip may occur over 10 minutes, it may occur over a few hours, it may occur over a few days, but the quicker you get that chest discomfort or shortness of breath or whatever it is sorted out, we say in cardiology, Ron, time is muscle. The longer you wait to get to that hospital, the more risk you have. And I've had people who've had bypass surgery have waited up all night with their chest pain for it to go away. It's complete madness to do that. But the final thing we need to talk about is what makes a stable plaque unstable? What makes it rupture? Because what puts it there in the first place is pure genetics. You might have insulin resistance. You might have a high lipoprotein little a. You might have familial hypercholesterolemia. You might have one of the more rare genetic conditions that puts fat in the wall of your arteries. But that's not what makes it go, which is the sudden rupture from stable to unstable. And it's always some stressor. Now, as you know, everything's in fives. Everything I talk about is in fives. There are,
Me too. It's 5
got,
fingers.
Yeah,
We had 6.
5 digits. Five
right.
digits. You have 5 senses. There are 5 seasons if you count Frankie Valley. So everything's in fives. So what are the 5 stressors? The 5 stressors are, number 1, emotional stress. So please show me someone who doesn't have that. Number 2 is work stress. And so there was a study called the Whitehall study where they took 17,000 British civil servants, followed them for 20 years, and they found that those civil servants who had the most heart disease were those who experienced job strain, which is defined as high demand, low control. So it was the middle managers who copped it more than the bosses. So work stress or mental stress is still very important, as is, of course, emotional stress. Number 3 is physical stress. And I'm not just talking about the physical stress of exertion, because I've said before, it's the second best drug on the planet, but it's the fat guy that runs for the bus who doesn't exercise, or in the US where they're shoveling snow, or these idiots who climb Mount Everest. It's not just the climb, it's the freezing cold temperatures and the low oxygen that can do that to your arteries, or the stress of having an operation, or the stress of chronic pain. Any physical stressor can do it. The physical stress of dehydration. There's so many different things that can bring on a vascular event. Number 4 is what we call pharmacologic stress. Now, what I'm talking about there is legal or illegal pharmacologic stress. So we're talking about, say, for example, it's okay to have a couple of cups of coffee every day, but it's not okay to have 6. So people who have 6 cups of coffee every day have a 20% higher risk for heart disease. So the dose is important. You might be a civilized human being that has 1 or 2 glasses of wine per day. But if you go out one night and have 7 or 8, that might be enough to make your plaques unstable. Not that a sensible human being like you or me would ever do this, Ron, but a snort of cocaine. I had a guy in his 30s with a very strong family history of heart disease who went out one night in a bucks night and had a few lines of coke, major heart attack. These things are not harmless. So marijuana is a great discussion. I'm on the board of a company called MGC Pharmaceuticals that's developing medical cannabis around the world. I totally believe in that. But you smoke 1 joint, you increase your heart attack risk 5 times. If you're a regular marijuana smoker, double the risk for heart disease. So any legal or illegal stimulant can bring on heart disease. And then finally, infective stress. We're living in the time of COVID, but it's not just COVID. It's also influenza. I spoke about in my radio show recently about the fact that last year we had 813 deaths from influenza in the Australian winter season. So far, we've had around 250 deaths from COVID and only 35 deaths from influenza because of the social distancing, the washing the hands, the reduction of big events. But any infective stress can inflame those fatty plaques and make them unstable and make them rupture. So when I see someone with a low calcium score who doesn't have advanced atherosclerosis, they typically have very significant inflammation going on in their bloodstream. So we're not just talking about cholesterol, we're talking about cholesterol, we're talking about blood pressure, we're talking about inflammation, we're talking about genetic predisposition to clotting. So these people that go on a plane from say Sydney to Heathrow and they get out and they've got a big swollen leg called the economy syndrome, they want to sue Qantas, they should be suing their relatives for giving the genetic abnormalities. There are about 8 specific genetic abnormalities that thicken your blood, and then with some sort of predisposing factors such as immobilization, that genetic thickening can come out and also cause a clot in your leg or cause a heart attack or a stroke. A young woman goes on the pill and within a month she's had a stroke. She wants to sue Bayer because they made Yaz. No, she should be suing her parents who gave her the genes to thicken her blood. The oral contraceptive pill just precipitated the problem. So you can see there those 5 significant stressors can bring out a problem if you have stable plaque. So I say to my patients, what's the best way for them to have a heart attack? It's easy. I say, start smoking, put on 20 kilos around your gut, eat whatever rubbish there is to eat, do no exercise, and make your life as complex and difficult as you possibly can. You'll have a heart attack, and I'll have a sip of tea while you ask me the next question.
Ross, this happened the other day when I was sitting in your office and I thought, I wished I had my microphone, and now I do, and I get to ask you all these questions and you answer them. We love simple solutions though, don't we? And I hear you talk about it's not all about cholesterol, but gee whiz, your profession, the cardiologist, I mean, that's not the message that we get from doctors and from cardiologists. I mean, how does...
Mate, can I tell you something? I was at this European Society of Cardiology meeting last year. One of the world leaders in cholesterol, one of the world experts, stood up and he said, I'm perfectly healthy, but I take 5 milligrams of Crestor every day just as assurance against having heart disease. And that is such a pathetic message to give people. Now, I'm not against statin therapy, as you know. I'm just against the inappropriate prescription of statin therapy and the emphasis to make people think that taking the statin is their major insurance. It is 10% of your management. 80% is lifestyle, 10% is pharmaceutical therapy, and the other 10% is appropriate supplements. But here's the key, Ron. Here's the key. Human beings are a sorry lot. Homo sapiens are a really sorry lot. If I line up 100 people and suggest the same treatment, whether it be lifestyle modification, pharmaceutical medications, supplements, or whatever, after 12 months, 50% of people have stopped because our ability to follow advice is not particularly good. Now, you're one of the world's greatest dentists. You tell people all the time they should be flossing. And so they go home and they floss for a few days and they get sick of it and they stop. Now, I'm an anally retentive neurotic, so I floss every day, as everyone should. But people are just not that compliant. And so you say, Ross, well, why is there still 17 million deaths around the world from cardiovascular disease? Because A, people don't look after themselves. Obesity, diabesity is the major epidemic of the 21st century. So they're still eating too much food. They're still not exercising enough. Exercise, available there to almost everyone on the planet. Only 50% of people do any exercise at all, and only 25% of people do the prescribed dose of 3 to 5 hours every week. 1 in 4. So that means 25% are doing nothing, sitting on their bums all day doing nothing, and another 50% aren't doing the right amount. So we've got 25% doing the right amount, 25% doing nothing, and 50% doing some. I mean, it's dreadful.
Now, you know, when we've done programs, and I know I've heard you say this as well about insulin levels, and when I do a program on cancer, it almost seems like any single disease that we talk about, insulin levels are really important, which is the case here. And yet so much of the advice, you know, like I know I was on the Australian Diabetes Association website, their 75-year anniversary, and they were giving us the 10 steps to living life, and this was the key, I guess, with diabetes.
Yeah.
And step number 1 was have carbohydrates with every meal and stay on low fat. And you didn't, and I guess the key here was with diabetes. If you wanted to live life without diabetes, you wouldn't follow the advice of the Australian Diabetes Council.
Yep. Yeah.
What's going on there, Ross? What's going on?
Well, firstly, let's talk about insulin resistance. Okay.
Yep.
30% of Caucasians, 50% of Asians, and close to 100% of people with darker skin are insulin resistant. It's a genetic problem. But as soon as you expose those genes to Western crap, that's when the problem starts. So this is why you've never seen a skinny Tongan, because they're severely insulin resistant. And if you kept them away from Western rubbish, they would be thin, they'd be fine without any issues. The Pima Indians in America, in the 1920s, were these svelte young men running around the American wilderness. Then they put them in reservations. They have the highest rate of type 2 diabetes in the world. 60% of Pima Indians are type 2 diabetics. In Australia, it's 6% of the adult population, 60%. So 10 times more in the Pima Indians, because they're exposed to Western rubbish with background severe insulin resistance. And as you so rightly say, high insulin, well, it's not so much high insulin levels, insulin resistance with the insulin-like growth factors and all the other things, not only associated with cardiovascular disease, but also with cancer and Alzheimer's disease as well. We're now calling Alzheimer's disease type 3 diabetes. And because 70% of cardiovascular disease is directly related to insulin resistance, we have to start managing that. But the message out there is have carbohydrates. I mean, look, this is what I call white death. White death is sugar. White death is white bread, rice, pasta, potatoes, goes straight to the gut and causes abdominal obesity. And that's the issue. And we have to start getting the right message out there. And one of the big things I say to people, they talk to me about diets, and I don't believe in any fad diets at all. I think every person should be having 2 or 3 pieces of fruit per day, 3 to 5 servings of vegetables, servings about a half a carrot. And you say, well, that's easy, Ross. If it's easy, how come less than 10% of people do it? And those who do it have the lowest rates of heart disease, cancer, and diabetes in the community. And it's a simple thing to do. And it's got nothing to do with your damn cholesterol levels. And we have this message about low fat and low cholesterol. About 50, 60 years ago, a lunatic called Ansel Keys published this thing called the 7 Country Study. Now, if you can figure this one out, Ron, you're a smarter person than I am. He looked at 22 countries, published the results of 6 in a thing called the 7 Country Study. Huh? I mean, seriously? Because obviously the 16 countries didn't fit his hypothesis that fat and cholesterol caused heart disease, because fat and cholesterol don't cause heart disease. There is a component of cholesterol that causes heart disease, and it is small, dense LDL cholesterol. It is small, dense HDL cholesterol. So forget about this good and bad cholesterol, LDL bad, HDL good mantra that people shove around all the time. It's the components of the LDL and HDL that are bad. And if you've got a lot of small, that's bad for you. This is where size is important. The larger your LDL, the larger your HDL, the healthier you are. So you go to a doctor, got a 0 calcium score, your cholesterol's 7, your HDL's 2.5, your triglycerides are 0.7. Oh, gee, you need a statin. What? I mean, where does this come from? No, and what you need to do is shift from small to large LDL. So how do you do that? A high quality fat, high quality protein, low carb, low calorie diet. That's the way to do it. But we're being told, have your pastas and your white breads and everything else because it's full of good carbohydrates. No, it's not. It's refined carbohydrates. So when this lunatic Ansel Keys came out with the 7 Country Study, at the same time, a guy called John Yudkin in Britain came out and said, hang on a minute, it's not fat and cholesterol, it's sugar. He got shut down by the sugar industry because they're a more powerful industry than the meat and livestock industry. The Pure study, done by one of the best epidemiologists in the world, Salim Yusuf, came out in a couple of stages over the last few years. The first stage was 135,000 people monitored for 9 years in 50 different countries. And the Pure study showed that those who had the highest refined carbohydrate intake, 28% increase in death. Those who had the highest fat intake across the board, 23% reduction in death. Those who had the highest saturated fat intake. Go to any cardiac website, go to any nutrition website and see we should be avoiding saturated fat. Okay, so the highest saturated fat intake in Salim Yusuf's trial, the PURE study, showed a 14% reduction in death. Hello? And then the most recent part of the PURE study, 220,000 people, 9-year follow-up, 50 different countries, because they added another couple of cohorts. They found that if you had, wait for this, 100 grams of red meat per day and 2 to 3 servings of high-fat dairy, not the low-fat rubbish, you had a 25% reduction in cardiovascular disease and death just by doing that. Now, again, I don't mind people making comments, but back it up with a bit of damn science.
Ross, I just have to remind our listener, we're listening now to, an cardiologist giving us this kind of advice, which I love. But, and back onto those small and large particles, part of it also is that they're oxidized, and that's part of the problem with the insulin instability too, isn't it? That it makes the whole thing more reactive. That's why we take antioxidants to deal with oxidized problems like oxidized LDLs.
No, but just see again, if you listen to conservatives, supplements don't work. Because let me tell you why, and this really drives me nuts. There's a little known university in America called Harvard, one of the top 3 learning institutions in the world, Oxford, Cambridge and Harvard. And they've been doing for the last 30 years the male physicians trial and the nurses health study. And we'll take multivitamins for a second, which is not loaded with antioxidants, but it just have a lot of good general nutrients in it. And they found that if you take a multivitamin for up to 10 years, it does nothing, waste of time. But when they analysed the data in 10 years in the male, this is a randomised controlled trial, there was an 8% reduction in cancer and cataracts in the people who took a multivitamin every day. Then they looked at the observational data at 15 years in the nurses. So we're talking 180,000 people in various guises in this trial. So a huge amount of data. So the nurses who took a multivitamin every day for 15 years compared with those who didn't, so this was observational, not randomized control, there was a 75% reduction in bowel cancer, 25% reduction in breast cancer, 23% reduction in cardiovascular disease. Then they looked at the males at 20 years. Those who persisted in taking a multivitamin for 20 years, and there's not many people who do, you're looking at one right now.
You're looking at one too.
Yes. So the people who did had a 44% reduction in cardiovascular disease just by doing that. And that's the point I'm making. So reduction in heart attack, stroke, stenting, the whole thing by taking a multivitamin every day. So, for example, people say, vitamin E is dangerous. There was a study done in 2004, or presented in 2004, meta-analysis by a guy called Edgar Miller in the Annals of Internal Medicine. And the title came out, Vitamin E not only is useless, but it may be harmful. And when you looked at his stuff, he looked at 11 trials of high-dose vitamin E. So we're talking about somewhere between 400 to 800 international units a day. And it showed vitamin E, firstly, didn't prevent cardiovascular disease, and there was a slight trend towards extra deaths in that study. But here's the drum. They used synthetic vitamin E, which I agree is rubbish and shouldn't be used. It's the El Cheapo version. So when you're doing a big randomized trial where you're supplying the vitamins, you get the cheapest version of it. But there've only been 2 trials in the history of evidence-based medicine where they used natural vitamin E, D-alpha tocopherol, not the synthetic stuff, D-L-alpha tocopherol, and they combined it with vitamin C, because a lot of people don't realize this. Vitamin E doesn't work without vitamin C. They're sort of blood brothers that work together. And in both of these trials, one called ASAP and the other one called IVUS, I-V-U-S, one is in a group of people with some carotid atherosclerosis and just watching the progression of that. And another was in people post-cardiac transplantation. And they found a 25% reduction in the progression of atherosclerosis in the people who were given natural vitamin E with vitamin C. But you don't hear any conservative doctor coming out with that because it doesn't suit their argument. So I'm saying when you hear people say vitamins just give you expensive urine, they might, but they also give you very valuable blood. And that's the message we have to keep pushing. So I have an association with a company called Bergamet. or it's actually the company's called Nat Health, but they make this thing called Bergamet Pro Plus, which in my extremely biased view, because I have an association with the company and I do all the research with the Italians, I'm an honorary Calabrian citizen because of my services to the bergamot fruit. So this is fruit grown in Calabria, so you've got to get this Calabrian product. And this stuff, this Bergamet Pro Plus, incredible benefits in activating AMP kinase, so keeping the weight down, shifting you from small to large LDL. We published stuff in the Journal of Clinical Lipidology on this. It enhances statin therapy. We gave people 20 milligrams of Crestor or rosuvastatin, dropped their LDL 56.5%. Then we cut it in half to 10 and added the Bergamet. We dropped their LDL 52.5%, but a much bigger drop in triglycerides and a much bigger rise in HDL in the people given the combination of lower dose statin with Bergamet. So it's my view, very biased view, that everyone over the age of 50 should be taking it twice a day, just routinely, twice a day, not once a day. And because of its benefits on small versus, or pushing you from small to large LDL, reduces diabetic risk, fatty liver. We've got published data with fatty liver, and also improves the microcirculation of your brain. A study out of the University of Manchester, not our lab in Italy, the University of Manchester showed that it also suppresses cancer stem cells. Why? Because it's the juice of the bergamot orange that has a huge amount of polyphenols, very strong polyphenols or plant chemicals that have an effect on all aspects of metabolism, especially activating AMP kinase. But why people aren't doing this?
Yeah. Now, Ross, I was sitting at my desk here a few days ago and up flashed an article from the Australian Doctor, which all doctors get in Australia, and it was lauding this breakthrough. Breakthrough. It was on coronary calcium CT score. Now, you know, this was a major thing, and here we are. Where are we in 2020, August 2020?
Yep.
And the listener may have missed it, but you first were doing coronary calcium CT scores. You introduced it into Australia.
I introduced it with the Sydney Adventist Hospital and another cardiologist called Dr. David Grout in 1999, and I was saying exactly this back then, and I actually got vilified by many of my conservative colleagues for doing so. And I've been saying for years, this is the best predictive test for heart disease. Now, this study out of a very fine place in Melbourne called the Baker Institute, headed by my colleague, very, very good and well-respected cardiologist, Professor Tom Marwick, superb cardiologist, one of the world experts in echocardiography. Tom came out in the news the other night suggesting that coronary calcium scoring was the best test for cardiovascular risk. And I'm thinking, really? Oh, that's interesting. And they took 1,000 people with a strong family history of heart disease, and they did calcium scores, and it changed the management in 40% of cases. So people who were deemed high risk, now low risk. People who are deemed low risk, now high risk. So it means that you can then make appropriate decisions about statin therapy based on the coronary calcium score. Now, I only said that in 1999. I saw a patient yesterday who I'd seen back in 2007, and I said exactly that in the letter that I wrote to the GP. So this has been around for years. The studies are just overwhelming that the coronary calcium score is easily the best predictive test. And it's my view, Ron, that all men at 50, all women at 60 should have a coronary calcium score, just like you'd say, okay, I'm 50 years old, 50-year-old male, I'll get a PSA done, I'll have my kidneys and liver looked at, my sugar levels checked, my cholesterol checked. But at the best test you can have at that stage is the coronary calcium score. Now, why do I say men at 50, women at 60? Because women are typically, not always, typically protected by their hormones until menopause. Now, I saw a woman 3 days ago who was in her early 40s, and she already had a calcium score of 152. And the last thing she wanted was to be on a statin from the age of 44. And I said, look, if it was me with a calcium score of 152, I'd take one. But I said, it's your body. So I gave her the Bergamet. I markedly reinforced the vital importance of lifestyle. And she's going to come back in 12 months and have another assessment, not another calcium score. You only do them every 5 years. It is low radiation. And when we're talking about calcium score, I want to bring in something here about the intravenous CT coronary angiogram. The intravenous CT coronary angiogram is done on exactly the same technology, but the difference is you get squirted with dye, and it has, and there's not one paper in the peer-reviewed literature showing any predictive benefit of the CT angiogram over the calcium score. But what it does do is make your wallet $500 lighter. you glow in the dark for a few days afterwards on some machines because of the radiation dose. And also, you're getting an intravenous dye that you could have an anaphylactic reaction to, or it may even damage your kidneys. I'm not saying it will. So why are people doing this as a screening test? There's no evidence at all. So there's not, as I said, not one paper in asymptomatic people that the CT angiogram gives you any extra benefit, but it's much more inconvenient, and it requires intravenous dye, and it's more expensive. We just shouldn't be doing it, but it's being done routinely by everyone around the place, and it should not be done. Do the calcium score.
Now, a part of the problem, and you were talking about the expert on cholesterol getting up and still touting it all, is that people's whole reputation, their whole professional life has revolved around a certain approach to this, and that's just not going to be surrendered very easily, not to mention how much money is generated. I think I had a figure of Lipitor alone has sold about $120 billion worth of sales. So
biggest selling drug on the market. And I would take Lipitor and Zocor off the market because they're fat soluble. I only use the water soluble statins, rosuvastatin, Crestor, Pravastatin, Pravachol, if I think someone needs a statin, if I think they do. And of the 19 million prescriptions written for statins every year in this country, I would suggest to you probably 500,000 to 1 million are necessary. The other 18 million shouldn't be prescribed. And when I say 19 million prescriptions, that doesn't mean 19 million out of our 25 million. With a script for statins, that's 12 scripts per person per year. So the scripts last for a month. So it's less than 2 million people, but still 2 million out of 24 million is a hell of a lot of people. And most of those are inappropriate.
And do you think, I don't want to get too technical here, but do you think people who are on statins should be on CoQ10 or other things like that?
When you say CoQ, I think everyone who's taking a statin, so if there's a good reason to take a statin, I think everyone should be taking ubiquinol, not CoQ10. CoQ10 is the standard ubiquinone, is the inactive version of coenzyme Q10. Ubiquinol is the active version. And what happens in the body is there's an enzyme called diapherase that converts you from ubiquinone to ubiquinol. But here's the problem. When you hit 50, the diapherase enzyme drops off, so you don't get as much active ubiquinol in your mitochondria. Because what statins do is they work on a particular thing called complex 3 in the mitochondria to deplete CoQ10, which is why it's felt that people get aches and pains with statins. So I give all my statin patients 100 milligrams, 100 to 150 milligrams of ubiquinol every day. I also give them magnesium orotate. Now, it's not the magnesium, which is good for you anyhow. It's the orotate that lifts up the CoQ10 in the mitochondria. So I give them magnesium orotate. Everyone gets Bergamet under my watch, and I have to always talk about my association with the company there. And I give them vitamin K2, and it has to be a dose of 180 micrograms a day. That's the evidence-based dose. It takes the calcium out of your arteries and puts it back in your bones where it belongs. So you get 2 bangs for your buck with vitamin K2. And I also give them Kyolic aged garlic extract. Now, there's a wonderful preventative cardiologist in the US called Professor Matt Budoff. He works in Los Angeles. And he's done some really elegant work where he gave people 4 capsules a day of Kyolic garlic, and after 12 months had reversed their coronary artery disease with a completely natural product. So when you're adding all of these things together, you're getting a much better effect. I use a whole lot of other stuff. And I've got to say, Ron, I think we should have another session on the future of medicine. But I think...
What time? No, it's all right. Keep going.
But I think one of the big deals in medicine is going to be, and not 20 years away, I think maybe 5, at the very most 10 years away, is you'll come in to see me and I'll say, Ron, I think you need this drug and these 3 supplements. And you'll take that script round to your chemist and they'll compound it into a nano pill. So you might be on 3 or 4 pharmaceuticals and 4 or 5 supplements, all in the one small pill you swallow every day, time release of the different nanoparticles. And also the other exciting thing is the micro patch technology. So a patch the size of your fingertip goes onto your arm, so you don't need vaccinations. You'll get it all through this micro patch. All these new therapies. This is one thing they're developing in Harvard now, diabetes. Instead of pricking your fingers 3 or 4 times a day and injecting yourself, this patch monitors your real-time blood sugar level and delivers insulin into your system. So you put a patch on every day, rather than getting there and pricking your fingers and injecting yourself. And we're talking, it's already been developed. We just have to, it just has to be commercialized. There's so many exciting things happening. So imagine your whole medical management being mostly lifestyle. Don't ever forget lifestyle. And then putting a patch on every day or swallowing one pill.
Yeah, and then all we'll have to do is convince the 90% of the medical profession who have been saying all of that's a total waste of time, that maybe it's worth considering. That's going to be probably the biggest challenge of it all. Listen, let's just
hang on, mate. It's only taken 21 years for them to
that's what I mean.
Story.
And it's actually a sobering story, Ross, was that I read, you will have known about Semmelweis, and the fact that this guy had the audacity to come up with, of all things, the idea that maybe you should wash your hands. It took the medical profession 10 years to accept that. The guy ended up in a mental institution dying. But anyway, we digress. Yeah. I want to talk about your thoughts on how we are approaching our current pandemic.
Okay. Look, I think in many ways in Australia, we've done some good things. So I think shutting the borders down has been important. I think maybe New South Wales have been a bit slow to shut the borders down between here and Victoria. I don't agree with that. And we know what's happened in Victoria has been a tragedy. But I think the whole concept about pushing the social distancing, washing your hands regularly, wearing masks in public, and also shutting down big events, I think that's been fine. But I have a concern, as I always have a concern. I don't agree with the authorities on everything. And mind you, we were told by some of the so-called health authorities at the start of all this, we would see 150,000 deaths in this country and 15 million cases. I mean, seriously, where's the evidence of that nonsense? That's scaremongering nonsense, because the government had to take the advice of their so-called medical experts. And we haven't seen that. And so we've had the country shut down because of this. Now, this is where I'm concerned about people's knowledge of how these things work. There's a thing called herd immunity, which even the microbiologists suggest, and I don't agree with them. Herd immunity is when 70% of the population have been infected or 70% have been vaccinated, and so therefore everyone's protected. That's not how I see herd immunity. How I see herd immunity, as you know, as a superb health professional, a virus is not a living organism. It needs a cell to exist. And all it basically is a bit of junk genetic material with a few spikes of junky protein coming off it. So in the case of the coronavirus or any coronavirus, it's an RNA virus hooked up to these little spike proteins that you see with the newsreader and the things coming behind them as they're chatting away. And when a healthy immune system, i.e. a child, gets exposed to a bit of this junk protein and junk genetic material, its healthy immune system chews up the stuff and spits it out into the environment. So you have a car crash and your headlight's out there, you still know that's the headlight from the car. It just doesn't work anymore. So if the child spits out a little bit of immune material, they can still induce an immune response. So the body, it's still recognized by another body that it's part of the virus, but it's not going to cause an infection. So I think children should have been going to school from day one. Teachers below the age of, say, 60 should have been going to school and teaching them, because you want to spread little bits of the virus, you see, because there's two components here. One is what I call viral load, and the other one is your own inherent immune system. And so with viral load, it's the dose. So if you're a healthy health worker in a hospital looking after 6 or 7 very sick COVID patients, they're pouring a huge dose of the virus into the atmosphere. And even a healthy immune system can be overwhelmed by that. If you're on one of these floating Petri dishes called a cruise ship, with the recirculating air going through, the virus is coming through, the whole thing, people are all packed in together, that's viral load. So people can get very sick in that environment because of the huge dose of virus they get. But then the only other people who get sick from this are people who either are sick, elderly and vulnerable, and if anyone is listening to this, it is vulnerable. There is no such word as vulnerable. Always put the L in there. So sick, elderly, vulnerable people, and even with a bit of virus, they can get very ill and even die, as we've seen with what's happening in high dependency nursing homes. But then occasionally we'll hear a 30-year-old in Victoria died recently. And occasionally you'll hear of younger people who died. But interestingly, there were 2 brothers in Holland who died from COVID-19. One died, so the other got severe COVID. So they mapped the entire genome of these brothers who were healthy up to that point. Both of them had a defect in the TLR7 receptor, toll-like 7 receptor, or toll-like receptor 7. And they found that that was vitally important for the functioning of a normal immune system in terms of dealing with these sort of viruses. So the problem with, Ron, as far as any sort of health advice, you are never going to save everyone. And it's a bit like we had a 15-year-old boy taken by a shark and killed a few weeks ago on the north coast of New South Wales. Now, does that mean we stop everyone from going in the water? We see people dying in car accidents. Should we stop everyone driving cars? So we can't shut society down because occasionally there will be younger people dying from this. So the way I would have done it, and I'm not a public health person, I'm just a medical educator and doctor. I would have sent kids to school. I would have sent young people out doing what they normally do. I would have stopped the big events. I completely agree with that. Mm-hmm. Masks, social distancing, washing your hands, agree with all of that. And I would have quarantined to some extent people over the age of 65 and been very careful with anyone who has an immune problem, sick, old, vulnerable people. That's how I would have done it. And let the virus spread through the community in healthy people. Interestingly, a study came out the other day showing that the harmless coronaviruses, which cause the common cold, and see, one of the things is this transgenerational behavior, transgenerational living. If you're a grandparent and you're hanging around with the grandkids, they've always got a snotty nose. And a third of the common cold are these weaker coronaviruses. And it's shown that if you have exposure to that, you have a better immunity to the coronavirus. And to be frank with you, I think I had COVID in February. I lost my taste for a week. This is before anyone was even talking about this. And I felt crook. But I get grandchildren. I've got 8 grandchildren. They're with me all the time. And so I was sick for a week. And also, interestingly, I had the BCG vaccination as you would have had when you were younger. As a health professional, you've got to have a BCG vaccination. And some of the work shows that gives you extra protection against getting really sick from COVID. So I think there are a lot of things we're probably not doing right. I interviewed Professor Tom Borody on my radio show the other night. He reckons he's got a treatment for coronavirus that's highly effective and it's already available. Ivermectin, which is an anti-parasitic drug for scabies and other forms of parasitic infections. So he gives ivermectin on day 1 and day 4. He gives doxycycline, a well-described simple antibiotic, 50 milligrams twice a day for 10 days, and gives 40 to 50 milligrams of zinc picolinate every day with that as well. And he's got some work out of California and Bangladesh and a few other places of Southeast Asia, where people who've had mild to moderate coronavirus have immediately, or over a couple of days, have got better very quickly with no progression to severe coronavirus. I think it needs to be done in a bigger trial, but hey, if you're getting some good results, try it.
I mean, it is interesting, and I'd heard the statistic that between 1,500 and 3,000 people a year die of influenza in Australia, and is that too high? Maybe it is.
Too high. I think it's somewhere between 800 on the really bad years, about 1,000.
But we've kind of, and I agree with you. I mean, I think the way we've approached it in the unknown, not knowing what we were dealing with, all that lockdown, all the hygiene's a great idea. But I'm just annoyed that I don't hear very much about our immune function, about ways of improving. I mean, to me, we've got the attention of the world now, like never before on health, and they've heard about comorbidities. What an opportunity.
Well, can I say the best way to keep your immune system healthy is the 5 keys of being healthy.
Yes.
And it's having fruits and vegetables, and taking high quality evidence-based supplements, having some vitamin C every day, having the Bergamet Pro Plus, having your kyolic garlic as just some examples of, and zinc's been shown.
Vitamin D.
Vitamin D. Let's talk about vitamin D.
Yeah.
Some of the studies have suggested that those people who have the highest levels of vitamin D, now let me make the point, there are no studies showing treating COVID with vitamin D improves it, but the studies have shown that people who have the highest vitamin D levels have the lowest rates of COVID, the lowest rates of progression to severe COVID disease, and the lowest rates of death. So I like people to run their vitamin D levels for many reasons at about 100, I think it's nanomoles per litre or whatever the figure is, but around 100, where normal is about 50 to 150. And so people with a very low vitamin Ds really cop it. But it's not just for COVID. It improves all aspects of your immune system. It also reduces your risk for osteoporosis, heart disease, cancer, multiple sclerosis, type 2 diabetes, depression, asthma. So why aren't we even thinking about these things? And because everyone was vitamin D crazy about 10 years ago, the government really clamped down on people doing vitamin D levels. But I mean, mind you, these things are probably more predictive than cholesterol, and we're not even looking at them. So this stuff does my head in, Ron.
The other one, Ross, was I've heard the way we thought of the complications initially, and I'm not being critical here because we didn't know what we were dealing with, was very different from, because there's something about the ACE receptors that are linked to the way the virus, complicates things.
Yeah.
Can you talk a little bit about that? I mean, because you were talking about blood pressure, and ACE inhibitors are a common blood pressure.
Yep.
So there's a kind of a catch-22 here, isn't it?
No, I don't think there is.
No. Okay.
It's called the ACE2 receptors.
Yep.
And that's felt to be the way the spike protein hooks into the lungs and takes the virus into the lung cells, into the immune system lining the respiratory tract. But interestingly, the severe version of COVID is felt to be a cytokine storm, where the cytokines just pour into the lungs and melt the lungs away and eat the lungs up, and you're left with this honeycomb lung. Well, the ACE inhibitors and the angiotensin receptor blockers actually block that cytokine effect. So if someone's on an ACE inhibitor or an ARB, they shouldn't be stopping their drugs. Could they be more susceptible to getting a slight dose of COVID? Maybe. No one's really proven that yet. Could they be susceptible, or could they be less susceptible to getting the severe COVID? Maybe. But there's no evidence at all that taking ACE inhibitors or ARBs gives you a bad dose of COVID. And I think one of the best things you can do is, if you get COVID, to get an immune reaction to it, and it's gone. So look, I'm not demeaning COVID at all. 80% of people that get COVID get a minor illness, they get over it in a few days. The 20% left, half of those people get a moderate illness where they get a bit sick, maybe like Boris Johnson, their oxygen drops a bit, but then they recover. But the 10% of people who get severe COVID, they're the ones who are in trouble. A third of those die, and typically the sick, older, vulnerable people. But of that 10%, many are left with problems. And they've done a fair few studies overseas with people who've suffered this, and they showed that 30% of people are still short of breath after 4 to 5 months, and up to 50% can have some cardiac effect, even if they didn't have underlying cardiac disease. So you mentioned comorbidities, but we're talking about people still getting sick with heart problems, even if they didn't have heart problems. 20% of people have neurocognitive problems. And many people are tired. They feel dog-tired. About 50% of people are very tired. And interestingly, one study out of Italy where they took 6 out of 150 people actually lost a limb from it, because it thickened. What COVID does is thicken the blood. So right at the moment, this is how I'd be managing it, apart from working on the vaccine, which I think is very important. And there's some very good work on the vaccine coming through, by the way. Study on rhesus monkeys. They gave the rhesus monkeys this adenovirus, this altered adenovirus, hooked to an immunogenic spike protein of COVID. And they found in these monkeys that there was a robust immune response. When they then exposed them to coronavirus 2 months later, none of them got sick. Nothing found in the lungs. One monkey out of all of them had a trace in a nasal swab, and that was it. But none of them got sick from coronavirus. So that's promising. The Oxford trials of a very similar vaccination, just over 1,000 people, showed that almost all the people in the trial with one shot had a robust response. With 2 shots, all of them were protected against getting antibodies and a T-cell response. They haven't been exposed to COVID yet, so we don't really know if it's worse.
So Ross, given your healthy respect for both pharmaceutical and appropriate supplementation, if somebody was experiencing the severe symptoms of COVID and moving into really emergency, what would you be doing?
Well, firstly, to draw on Tom Brady's comments, I would certainly, if someone was moderately sick and with proven COVID, I'd be giving them the ivermectin, doxycycline, zinc regimen over 10 days. Okay, so that'd be the first thing. If they got sicker and had to go into a hospital, and we monitor their oxygen levels. As soon as the oxygen drops to 94, that's when you hit them hard with other stuff. So I'd be giving the remdesivir, which is intravenous injection. I'd be giving them high-dose dexamethasone, steroids, and also I'd be giving them some prophylactic blood thinner, along with oxygen therapy and possibly ventilation. And I think that at the moment, that's the evidence base we have. There's a few newer things coming through which are being suggested. Some look pretty exciting. But that's what I'd be doing at the moment until we had these other treatments that are getting an increasing evidence base. And then as soon as we get the vaccination, I'll certainly be putting my hand up for it. And I think that's all we can do at the moment. And mind you, it's a hell of a lot more than we can do for, say, influenza. And I hear some people say, oh, look, this is much worse than influenza. Well, influenza can still cause, I've seen people die from influenza. I've still seen people get cardiomyopathies from influenza, get severe pneumonia. So it is still a bad illness. I don't think we should say, oh, influenza is COVID's younger brother or younger cousin. It's a much older. And you think about in 1918, 1919, 50 to 100 million people in a much smaller population died from the Spanish flu. So, and I'm not suggesting that we've ever seen an influenza like the Spanish flu since, but we just don't know because influenza mutates every year. And maybe COVID will mutate. It's mutated a little bit. I think it's probably a little bit more contagious now, but I don't think it's any more virulent than it was when it started.
It's interesting to consider the Spanish flu because it came on the end of the Great War, which would have compromised many people's immune system on so many different levels.
Exactly. When we had no idea about the immune system, but just it's not even that. It's coming back from the war, and the soldiers brought it back from the war. When their immune system was just shot to pieces, without wishing to use that dreadful comment. But I'm saying their immune systems would have been gone. They would have had the enormous stress, the malnutrition from being in the war. They brought the Spanish flu back, and no one had any idea about high quality fruits and vegetables. For example, there was no such thing as vitamins, minerals, or trace metals back there as being a treatment. So we're in a completely different era than when we really modern medicine wasn't invented. It was pretty hopeless.
Ross, just finishing up, last question now, because we're going through some pretty challenging times on so many different levels. What do you think the biggest challenge is for us moving forward at this time?
Well, I think the biggest challenge at the moment is getting through COVID. And you see, this is the point, Ron. We talk about the dreadful infection, but what about the incredible effect of social isolation, of losing your job? In America, they're suggesting that 35% of the excess deaths around the time of COVID were due to the fact that people weren't seeking attention for their heart disease or their cancers because they were scared of getting COVID. So they're not getting proper medical attention. So people should still be going to the doctors with all of their other issues to get those sorted out, because you can die of heart disease or cancer or any of these things. So that's the first thing. Secondly, we've got to look at our medical system here, which in my view is the best medical system in the world, because even the poorest person in this society can go to a major teaching hospital and get high quality service. In America, if you don't have any money, you lose your job because of COVID in America, you can't afford healthcare. So you don't go to a hospital, and that's one of the reasons these people are dying. And then finally is the enormous stress of this illness. Just think of our Victorian brothers at the moment, having to stay home, having a curfew. You can't go off after 8 o'clock. And many of us with the first world problems of all, we can't go to restaurants. These people, their lives are shut down by this, and many people are losing their jobs. So I think the real challenge now is rebuilding the society after this enormous effect of the virus. Hopefully the virus will fizzle out. I can't say that it will, but hopefully it will. But even if it doesn't, we hopefully will get an effective vaccine. We certainly are getting better treatments for antiviral illnesses, but we also have to realize there are other things that are happening in society, and they need to be. So I think the biggest challenge is looking at the global effect of this virus, not just from an infection viewpoint, but from a societal and economic viewpoint as well, and at a personal viewpoint of what it's like. For example, you think about this, Ron. Your dear sweet grandmother, who you've loved for years, is in a high dependency nursing home. COVID's going through the nursing home. You can't even go in and say goodbye to her. And imagine dying alone. I think that's just an incredibly sad thing, that there are people who have to die alone because of this dreadful virus. So we've got to think of the emotional impact as well, and the long-term emotional effects of all of this.
Ross, thank you so much for joining us today. I really appreciate your time and sharing your wisdom with us.
My absolute pleasure, my dear friend. Thank you.
So there it is. I guess the takeaway message is, there was so much in that episode. You really need to go back and have a listen to it. You need to have a read of the show notes. I know I will. We'll have links to that article about the coronary calcium CT score. And I know that Ross has been talking about it for so long, and here we are 20 years later, the rest of the profession has caught up. And I have to say, the medical profession are slow to take on new information, and they're slow to embrace anything that doesn't come from the pharmaceutical industry. I hate to say that, but it's true. And I've covered that, and I will cover that in some other podcasts that I've done. One particular one, The Elephant in the Room, where I cover some of the issues about evidence-based medicine. But so many pearls in that, and finishing on the note that we really have to be thinking holistically. I agree with Ross. I think the hand washing, I say to my patients now, which I normally would go out to greet them in the waiting room and shake their hands, oh my God, that's just so dangerous. And I've got a smile on my face. But when you think about it, shaking hands, well, maybe it was good for cross-contaminating in our microbiome, but it also potentially was a vector for disease. Who knows? But I think the idea of hygiene and being careful and not having big gatherings is really probably important during this next year or two, and even not travelling may be a good thing. I know I'm going to be exploring my state, New South Wales, because I'm not going to be getting on a plane anytime soon. But looking at this thing holistically and looking at the effect that it's having on our mental and emotional well-being as a society, really important. So I so enjoy talking to Ross, and I so respect his views on so many different things. So by the way, go and leave a review on iTunes, because I think these messages these topics that I talk about are really important ones, and they need to get out there. So it pushes up the ratings. There's my plug. And we've got some amazing other exciting things planned for the latter half of this year, so stay tuned for that. I hope this finds you well during these very challenging times. So until next time, this is Dr. Ron Ehrlich. Be well. This podcast provides general information and discussion about medicine, health, and related subjects. The content is not intended and should not be construed as medical advice or as a substitute for care by a qualified medical practitioner. If you or any other person has a medical concern, he or she should consult with an appropriately qualified medical practitioner. Guests who speak in this podcast express their own opinions, experiences, and conclusions.